Suhag Jewelers, timeless jewelry for generations.
Good evening, everyone. Welcome to the show Fight Against COVID 19. I'm your host, Dr. Shefali Agarwal. Thank you for liking, subscribing, and sharing our show. With this show, we are able to connect to many people, including frontline healthcare workers, people who are making masks, people are contributing in this fight against COVID 19. We have done this show with many people across the United States and brought some wonderful people who are doing so many things to support this fight. Today I have a very special guest who's really analyzing the data and trying to give us guidance both in US and in India about COVID-19. I have Dr. Mukherjee, who's the chair of biostats in University of Michigan. Hi, Dr. Mukherjee.
Hi, Shefali. Thank you for having me on the show.
Thank you for it's our pleasure that you're on the show. So, Dr. Mukherjee, tell me a little bit about yourself and what you do.
So, as you mentioned, I'm the chair of biostatistics. I live and breathe data, and I came to the United States as a doctoral student in 1996, and I have been a lover of data and as it applies to biomedicine and public health. So, we are located within the School of Public Health. So, I work a lot with cancer center members as well as epidemiology and health behavior and education, environmental health. So, it's a very interdisciplinary, vibrant, data-rich environment at the University of Michigan. And when COVID happened, then we wanted to really contribute as quarantined health data scientists. We are all doing our part, as you mentioned.
Yes.
Everybody is contributing to the fight against COVID, and we contribute to the lens of analyzing data.
That's wonderful. So tell me a little bit about COVID-19, how you got involved, your contribution in terms of COVID-19 and the work you have done, both here and I think the contribution in India.
Thanks for the question. So I think that I still remember the day we started the COVID-19 work. It's very hard to pinpoint a day when you started research, but in this case, this is true. Uh, March 16th, the first day of stay-at-home orders in Michigan. And so we were a group of, scientists of Indian origin, wondering about our parents, wondering about when we'll be able to go back, particularly graduate students who were confined and they did not know. So we wanted to repurpose our anxiety in terms of something meaningful, something positive. So we started looking at the India data on March 20th when India had 536 cases and 11 deaths. So very, very early in the pandemic. And within 72 hours, we wrote a report what things could look like, because what we saw in US, what we saw in Italy, everything started very quietly and silently and suddenly exploded. So we wanted that report to reflect that reality. And that report played a very critical role in determining policy and prompting the early lockdown that India had.
Yeah.
But then we have ran with with the pandemic for the last 6 months, continuously updating our models. So that has been quite a journey for all of us.
So, tell me a little bit about your belief, statistically, in terms of the trend and we talk about the curve, how do you interpret this?
Yeah, so India has been very unique, as has been pointed out, that in most of the parts in the world, you have seen a flattening of the curve. And the curve has turned the corner after maybe 2 to 3 weeks of lockdown, and you have started to see the flattening and then the declining. So with 2 months, 9 weeks of lockdown, you expected to see a steady decline, which has not happened in India yet. So if you have heard about of course, due to media and due to all of our exposure to infectious disease modeling, we are very familiar with the concept of R, or the basic reproduction number. So on an average, how many people does an infected person pass on the virus to? So that has come down from about like 3.5 to 1.19 in India. But still, India is such a big country, you do have a large number of cases still. On a relative scale, it has slowed down, but on an absolute scale, you still end up in having 10,000 patients showing up at the hospital. 1.19 in India. Overwhelms the healthcare system. Such a big country.
Yeah.
So you have a large number.
Sorry about this.
On a
There is some lag in the voice. So, in terms of just trying to understand that how do you compare the cases between US and India?
Yeah, so in US, I think one thing which is similar between US and India is there's tremendous heterogeneity across states, right? So the concept of a national peak is determined by the states which contribute to the most number of cases to the total case count. So in India, it's Delhi, Maharashtra, now Tamil Nadu, Gujarat, Rajasthan, West Bengal, Uttar Pradesh. So these six states actually contribute to more than 90% of India's cases. So similarly, I think in US the curve is also very driven by hotspots. So to talk about a concept of a national peak is sort of like a nebulous concept in India
Yeah,
because what we see is really a cascade of peaks going through each of the states. And so that's why probably the curve has also not flattened because if one state flattens, then the other state is
it
bumping
starts
up.
pumping
So
up. Yeah,
that's why you are not seeing that. So we
yeah.
are doing state-specific models now.
So
But I would have to say that a lockdown or stay-at-home order in a Western world in a high-resource setting looks very different than
an
low-resource
Indian,
setting.
yeah, Indian setting. So, when you look at the Indian states, I mean, I know you've been contributing. First, can you get some, like, what are you contributing in India? How are you helping Indian? I know you're helping a lot of analyzing the data. What exactly is the contribution?
Yeah, so I think that we are evaluating different lockdowns and doing what is very critical for anticipating healthcare capacity, which is the projection. What will happen in 2 weeks if under various hypothetical scenarios, for example, if people re-engaged exactly as before,
Right.
things were, or people are modulated and cautious. And what about 80% of people wearing masks? How do you incorporate that in a projection model and say what would be the anticipated number of cases so
Yeah.
that people can plan in terms of
Yes.
their healthcare capacity. So we have had consulting roles with many state government officials, for officially, informally. Also, every morning, I think I wake up responding to questions by various different people
Yeah.
visiting our website, including journalists, policymakers, state officials. So that has been very rewarding.
Yeah.
And the way we set up our models, that overnight they get updated with the daily data automatically. So that automatic update has really helped us really have constant updates to the daily reflection of the daily reality through models. So that has been really rewarding.
Yes. So, Dr. Mukherjee, how do you see the different states? So, yeah, we talked about earlier, Punjab may be different than the others. What do you see differences in state patterns in India?
So I think that what has been really inspiring to me that people say that stay-at-home orders, non-pharmaceutical interventions is very hard to do high contact population density areas like India. But if you look at Dharavi, people have been able to bend the curve in a place like Dharavi, Asia's
Yes.
largest slum.
Yeah.
And so that is a proof that this type of social non-pharmaceutical interventions of social distancing works because what they did in Dharavi was actually to get access to marriage halls, schools, and
Wow.
sports centers to take people out and do a centralized quarantine because home quarantine is really not possible.
Yeah.
So
Yeah.
what I learned is that the truth in India is very context dependent and state dependent.
Right.
So, and one person can make a difference in terms of driving policy at a very grassroots level. So in Dharavi, all the doctors, they were not scared. They were all had adequate supply of PPEs. And there were constant monitoring in terms of the hypoximeter, temperature scanner, and anybody with mild symptoms were taken to the centralized quarantine facilities. So I feel this targeted type of approach, which is very different than anywhere in the world, had to be really applied at grassroots levels in India. So it has been quite inspiring to study that. And I think Karnataka, Punjab, Kerala have done really well. And if you look at their curve, they are showing the pattern that you expect going down, but then
Going
with
down.
increased stability, then there are few cases. You never can expect to go to zero or eradicate the disease. But when it's going down, then you can contain them with contact tracing, treatment. So then the situation becomes much simpler. So you definitely cannot get to zero, but you can get to a manageable number.
So, what are some of the challenges that other states that are not able to control are going through? What? I'm sorry if this question is naive question, but I just want to understand what are those challenges that they are going through.
Yeah, so I think that, I keep saying this and I sound like a broken record, that the public has a lot of role to play in public health.
Yeah.
So the community engagement and belief that this is really serious, wearing masks, not going out beyond the core functionalities and essential. It is true that it is not sustainable in India to prolong the lockdown and relock the country again, and there is no need to. But if we all manage our risks and think that we are going to do the bare like essentials so that
Yeah.
people can still earn their livelihoods and daily wages, I think people are frustrated and we have all been cooped up. So it's very natural to aggregate. But I think this is the wrong time to do. We have to make those personal sacrifices. And I think increased mobility because the migrant workers moving back to their
Yes.
homeland has really made it spread to the East Coast. So initially, most of the cases were due to travel, right, from the
Yeah.
Western Coast, and now it's all over the country. So big metros will unfortunately have to go through a peak, lower or higher.
So, what are the some of the challenges that you face statistically when you do this kind of modeling for India versus US, right? Because there are so many data points that may not be available, right?
So yes, so that's a huge. I was not going to comment on that. You asked the right question. That's the key issue. Here we can trust the data
Yeah.
because people are reporting the data. And right now, tests are widely available. You can get tested in Michigan without a doctor's order. So we
Yeah.
have a much better sense, much better grasp on what is happening. In India, often look at the data. I often question myself. I don't believe the numerator. I don't
Yeah.
believe the denominator. What
That's
am I
right.
doing modeling the fraction?
Yeah.
So the testing, the number of cases is very limited. India still has done about 5 to 6 million tests, but that's testing less than 1% of
Mhm.
Indian population.
Okay.
So compare like to other Western countries where they have done by this time 10%, 10% in most cases. So
Right.
there is a huge difference.
Sorry,
And
there's some background noise. I apologize. Go ahead.
yeah, there are some reporting of death data also. I
Mhm.
wonder about that because the causes of death, you need to
Mhm.
really specify that. I have been looking for some data at the same time historically and this
Yeah.
year with respect to SARI and illnesses. So, data being more accessible and transparent would really help the government educating their policy and their decision and informing in a data driven way. So I think that's a huge need.
So I think one thing that we say that India, is much apt for, any kind of infectious disease because we've dealt through that than a Western culture. So contact tracing, everything may be definitely better. But then you see challenges about whether how real that data is, honestly. So how do you balance that? Like I'm sure there are like measures that are already placed in India that are not here.
Yeah, so that's a great question again. So we do a lot of sensitivity analysis in terms of
Yeah,
our models. For example, if we pretend that 1 out of 5 cases were reported,
yeah,
or death rate was underestimated by a certain fraction, how
right.
would the situation look like? So we do a lot of things like that in terms of our models, presenting the best case and the worst case scenario.
Yeah.
And there's not so much of this when we model US data.
Right, right. So, I know you mentioned something like that you have been advising different official policies. What kind of advice do you give to Indian government or policy or other things? How do you advise?
So many times these are simple questions because one thing that we were able to do is to get our papers and our data out there so
Yeah,
people can use them and play around with them. So
yeah,
I know that many times government officials are looking at certain input data point in our app and
yeah,
asking questions, and
yeah,
I'm just clarifying. Many times they're consulting with certain consulting firms, and
yeah,
firms reach out in order to borrow our models to particularly customize for a particular state. and we
Yeah.
work with the consulting firm. So it has been a varied level of engagement.
Mhm. So you basically provide either modeling or advice at a consultant level, either to the government or what state level or at a central level.
So, yes, so because this is a policymaker's nightmare, right? Because things
Yes.
are changing on the ground
Yeah.
every day.
Yeah.
So the number of expected COVID-19 cases and deaths are only a piece of the puzzle
Mhm.
because you are trying to minimize this holistic cost of
Yeah.
human lives and livelihoods.
Mhm.
So this is one input in a policymaker's whole optimal envisioning and assessment of the whole situation. So
Mhm.
that's the ingredient that we try to provide. And then there are many models. And
Yeah.
so people can actually calibrate across models, but that's the input that we provide.
Yeah, so I think I'm going to ask you some very heavy loaded question is, the political system in India is so different. There's political parties, there's also this individual state level decisions versus, our Prime Minister was wonderful, Dr. Modi. So how, Mr. Modi, how do you balance that advice whether it's central level versus state level? Because each state is so different. It's not like, very much like US, the pattern's almost the same.
So I think this is, the job of a scientist to put out their material out there,
Yeah.
filtering all political biases and agenda aside. And
Yes.
with that truth, policymakers can take decision. They can throw different lights on the
Yeah.
data that you provide.
Yeah.
But your job as a data scientist is to use the best possible tools
Of
on
course.
highly imperfect data and get the best information out there. Because
Right.
the challenge is hard, but you still have to use the best possible tools and the best possible data science. So
Right.
if you look at our paper was commended. Actually, this is the first time I had the paper which came out with a 33-page response to reviewers
Oh
because
my
we are
God.
so rigorous about showing the sensitivity of our model to these anomalies and imperfections of data. And that's what you have to do. You put your
Yes.
best foot forward, and then the other people will use this in different
That's
prisms.
amazing. That's
Yes, you
great.
have to maintain that objectivity.
That's absolutely right. As a scientist myself or as a doctor, I completely agree with that. Tell me a little bit about, last few questions. I know we're running out of time, but we're really enjoying talking to you and learning so much from you.
Same.
In terms of how do you see US today? Like we talked about India and differences. How do you see United States today as you look at the modeling and other things?
Yeah, so in US also, as we all know, there is tremendous heterogeneity in terms of the US states, but we all have done quite a good job in staying at home and
Yeah.
have brought that R curve down. Michigan particularly has done quite well, but I think we cannot let our guards down. That's what I
Yes.
hear about US, that we are thinking that it is safe and to some extent with proper personal mitigation strategy. So I
Yeah.
think that we have been under really the strictest measures. Now, so we are forced. Now we really have to apply to our psychosocial conscience that
Yeah.
what we're doing here today is
Yeah.
affecting others. So
Yeah.
we really need to embody and live public health principles for a while till we have a vaccine or a treatment for us and for the sake of others. So I think that message getting through across uniformly throughout US states will be great so that we live with risks, right? Every day when we go out and we work, we live with risks. This is a different time by wearing masks, washing our hands, that we manage our own risks and minimize them.
So I think last two questions. The second last question is, how do you see curves today between US versus India? Like curves when you look at US, and how do you see curves in India?
So in
Like
US, in most of the states, you have seen that decline, right?
the
So
decline,
and
yeah.
and in some states after reopening there are recent surges, but still it's not enough to sway the national curve. So if you still look at like the New York going down, Seattle going down, LA going down, some of the Detroit going down has really brought the curve down. So in India, I feel we have flattened the curve. So if you think about a hill, the peak has been pushed. So
Yeah.
I my hope is that the number of cases which is happening in Delhi and Mumbai is really starting to overwhelm the healthcare capacity. So I'm hoping that we can scale up and get through this period and
Yeah.
maybe even consider modulated forms of lockdown in those hotspots so that the
Right.
rest of the country can still function. But we can also, optimally deploy resources from one state to another because not every state is going through the peak period at the same time. So
Yeah.
models can also be used to optimally deploy resources and PPEs and help one states. We need a tremendous cooperation and solidarity and resilience to get through this together.
Absolutely. So the last question I have is when you talk about a model, what data points go in there? Like somebody who's understanding model, what it is, what exactly? 'Cause we talked about so much about the model.
Yeah, so statistical models and epidemiologic models are sort of abstract realizations and conceptualizations of how real life natural phenomena happens or a pandemic really spreads in this context. So the models that we have been using are compartmental models, which have three compartments. One is a susceptible, infected, and removed compartment, and
I
that
see.
removed compartment could have recovered and deaths as well. And then we try to model the transmission rate from susceptible to infected and
Interesting.
then build in all of those nonlinear compartments in such a way with assumptions on incubation period, latency period, and try to project what would happen if I stop at time t, what will happen in 10
In the
days.
terms of infection rate and deaths and things like that. Got
Yes.
it.
So we predict all of those compartments, what would happen in the future based on the counts that we have seen, say from March 16th to June 20. What do we see? How can we project what is going to happen in July or August? What is the shape of that
And
curve?
then you readjust based on if it changes. You readjust the model as you go, depending on the incidents and what's going on in terms of cases and things like that, right?
Shefali, you did your public health, so that information is showing up, and so yes, absolutely, and that's why we felt that it is extremely important to actually update the models every day because the
Yeah.
reality on the ground is changing. One day in India, for example, there is a spike, and my model can have to capture that, cannot wait 7 days in order to influence policy. So that was probably the biggest sort of a force farsight and looking into the future that we had was to start early on was that we are not going to just stop writing a paper running the
Right,
model.
right, right model. Right. Get it.
Really be helpful in terms of providing real-time evidence.
So, first of all, it was a pleasure to have you. Somebody so accomplished, so humble, and doing so much for COVID. So, it's really, I want to tell you, it's an honor to have somebody like you who's not only helping here in the United States to do the modeling, but also helping India and, advising for health policies and many reasons. And this is an important part. I think we talk about many things like people making masks, healthcare, but this is also important because if we don't know the projections, how would we be prepared at the front line? So your contributions really, really appreciated. It's a big one. So thank you for being here.
Kudos
Uh, eh,
to everybody, all the frontline health workers all across the world who are really risking their lives to save COVID patients and other patients as well. We are just working from the sideline
oh,
in your
come
support.
on.
In your
Yeah.
support, yes.
No, no. So, any message to the viewers? A last question. Anything you want to say to the viewers?
So I think just personally, as a human being, not as a data scientist, I think that we have to really manage our own personal risks as we think about the next 9 months, 12 months, in terms of going back to work, in terms of resuming normalcy in our social
Yeah.
lives. It is going to be a hard time. And I
Right.
hope that though we are physically isolated, we can really come together like you and I would never have met
Yes.
and we have lived in this country for a long time. So we can come together and help each other and get through this period socially and not forget that COVID-19 is only one kind of death we are thinking about. But there, if we delay our care, if we are mentally depressed, then that will have a long-term effect
Yes.
on our.
And we are already seeing these kind of things. Mental depression is a big issue right now in US and India because you're alone. So I think you raise a great point and something that we'll be talking about in future with some experts. So really a pleasure to have you. Thank you for all the contribution you're doing. Really, it was an honor. And to my viewers, please take care, stay safe, stay healthy. Thank you very much.
Thank you so much, Shefali.